Welcome everybody. Really pleased to have so many people on our Zoom call this evening. Thank you so much for joining. My name is Barbara Nichols. I'm the Director of Adult Social Care in Havering, and I'm delighted to be able to host and chair the panel this evening. The purpose of the session this evening is really to present important advice in relation to the impact of COVID on women, and in particular in respect of the vaccine and pregnancy and other fertility issues, as well as any postpartum issues. We've got a great panel here this evening, which I'll introduce in just a moment. But just to note that we are recording this session and it will be made available on Havering's website, the council website, after the meeting. I'll move on to introductions then. So I'll ask each panel member when I call their name just to come on and say who they are. So Dianne.
Hi, I'm Dianne Addei. I'm a consultant in public health medicine. I'm a public health advisor to the National Specialized Commissioning Group. Thank you.
That's great, thank you. And Viv?
Hi, I'm Viv Cleary. I'm a consultant in public health that specialises in infectious diseases, and I'm working with Havering Council.
Aruna?
Hi, my name is Aruna Ramineni. I'm a consultant obstetrician and gynecologist, and I work in Queen's Hospital, Romford. I lead the fertility unit in.
That's fantastic, thank you. Anne?
Hi, I'm Dr. Baldwin, one of the GP in Havering and also clinical director for Havering CCG.
Okay, and Gemma?
Evening, everybody. My name is Dr. Gemma Barrett, and I'm a GP in Havering, and I'm a clinical lead for urgent care.
Okay, so just a reminder to participants, if you could keep your microphones on mute. Please post any questions that you've got that come up through the presentations into the chat function, and we'll do our best to answer them this evening, or we'll follow up with an FAQ pack that will sit alongside the copy of the video. Speakers will have their cameras on when they're speaking, but may turn them off in between times so that we've got enough room on our screens for the presentations. And just ask that in the chat that you keep your comments as respectful and thoughtful as possible. We won't be able to kind of tolerate any abusive or trolling comments. We'll be muting those, and as necessary, people may be removed. I'm not expecting that tonight, but it's an important thing for me to say from the beginning. So I think we will move straight on. And I'll introduce our first speaker, Viv Cleary.
Thank you very much, Barbara. Thank you. I will just check in with everyone. Can they all see my screen? Hopefully you can. I'll make it a bit bigger. Great. Thank you very much. I'm going to just spend 12 minutes or so talking about the vaccinations themselves, and how we've come to have these successful vaccines that we have. I've got the sort of the side effects and what's in the vaccine as well I'm going to talk about, and I'll also include some of the stuff about variants in this. So I'm going to start by saying the aim of an ideal vaccine is we're trying to produce exactly the same immune response that you would get if you actually got the disease without giving you the disease. So it actually mimics our immune system. And so it doesn't replace it. And I think sometimes there's some misconceptions that vaccines can replace the immune system, but actually what they do is they just mimic it, and they promote the body to actually make antibodies against the particular virus. The other two things we try to do with any vaccine, be it COVID, measles, mumps, rubella, is we're trying to generate this long-lasting immunity. Now, we'll just say there, we don't know yet how long our vaccines will last. We know that COVID infection probably lasts 5-6 months or so. A lot of the studies have shown. My best guess would be that it would probably last very similar to like influenza, so 6 to 9 months kind of immunity. And we have already looked at getting boosters in the autumn months. So I'm assuming in years to come that we may see COVID and influenza vaccines every autumn, and because of the way these viruses behave, which I'll talk about in a moment. And we're also trying to do this, interrupt the spread of infection. And the more people we can get vaccinated, the more we can bring case numbers down. And certainly also we can stop people becoming as unwell and need for hospitalization and obviously dying. Just going to talk about the two vaccines that we've got 3 vaccines actually, but they work on slightly different principles. So the Moderna and the Pfizer vaccines are mRNA vaccines. Now we've all seen this picture of the coronavirus here, and you can see as a coronavirus, it's got all these spike proteins on its surface. And if you're infected with coronavirus, those proteins, those spike proteins, latch onto your respiratory system, and then they sort of say, make copies. So you get hundreds and hundreds of these copies, and they overwhelm your immune response. So what these mRNA vaccines do is they take that spike protein, put it in a bit of this lipid coating, you inject that, and your body recognizes this as an intruder, and then says, okay, make antibodies to that intruder. So Pfizer, as I say, and Moderna are both based on that technology. And I think some of the questions I often get are, well, these have been rushed through, these vaccines are very new, but I think this is quite important to, when we think about these vaccines, this particular technology has been around for at least 2 decades, which may be a surprise to some people. And I know Dr. Addei is going to talk about the normal type of vaccines that we have used in the past, live vaccines and killed vaccines. So although these are new technologies, we have been working on this technology for the last 2 decades, looking at things like Zika virus and rabies. And so what we're trying to do here is a messenger RNA. It's the communication between cells. So I throw in a few of these things you'll see on Facebook, I'm sure, about it affects your DNA. And it's 2 different things entirely. So messenger RNA is a communication between cells. And as we know, DNA is a building block of us being human. So it doesn't affect our DNA. It basically communicates and says, if you see this spike protein, make antibodies. So that's what these messenger RNA vaccines are doing. So let's look at also the Oxford vaccines. These are the AstraZeneca or the Oxford vaccines. And also Johnson & Johnson is another vaccine that we're not using at the moment, but they work on the same technology. Again, this technology has been around. We've been trying to get Ebola vaccines, for example, using this technology. Now here, it's the same principles. Instead of wrapping this spike protein in a bit of lipid, we wrap it in this harmless adenovirus. So we wrap the spike protein in a harmless virus that's changed. It's harmless in humans, and then we inject people with that vaccine. And again, the body does exactly the same thing, recognizes the spike protein as an intruder, and then makes antibodies. And then what happens next time you come across someone and you're possibly infected with someone who's got coronavirus, your body will recognize those spikes and it won't be able to latch onto your respiratory system. Now, obviously, we know these vaccines, nothing's 100%, but they are, I would say, they're performing much better than we hoped for. Any of you have influenza vaccines every year, about 60 to 70% effective. These are running at sort of anything from 80 to 95%. And that includes things like getting actually symptomatic from coronavirus, includes the severity of disease, which is really important. And it also includes hospitalization and dying from these infections. So I'm going to just move on to the possible side effects, because I know these are in the news an awful lot. And I'm going to say all medicines we know have side effects. And these are what we saw in trial and what we're seeing in actually reality with our population. And any of you have had a vaccine will have had either something like a painful heavy arm, or you might have felt tired or had a headache, and general aches or mild flu-like symptoms. These are kind of the normal side effects that you get with these vaccines, or you may have nothing at all. I know obviously people that have had no side effects at all. And of course, this I think is quite a very important point we wanted to talk about tonight was you've seen again in the news and loads of information coming over from Europe, and we had this sort of kickstart, stop and start, didn't we, with this particular Oxford vaccine. And what we found is that there is a risk of blood clots with this vaccine, but the risk, I just wanted to say, is 4 people in a million. Now that risk of clot it's slightly higher by younger age groups. I'm just going to put that into context first of all, because if any of you look on a packet of paracetamol, you will see that there can be a risk of blood clotting. It's 1 in 1,000, which actually surprised me when I looked at the inside of the packet. So looking at that, comparing that with this, that would be 0.004 in 1,000. And also, if you actually get COVID, the disease, the risk of blood clots is 165,000 in a million. So I hope that puts that into context, because I know this can be quite scary, especially with all the news, but that's the actual risk. And the reason we've changed that to give 18 to 13 9-year-olds an alternative is because of this risk is slightly higher in younger age groups. You can see here 1 in 100,000 for people in their 40s and 1 in 60,000 for people in their 30s. So really, the Joint Committee for Vaccination Immunisation have actually advised this as really not a safety concern, but just for the utmost caution with that particular vaccine. Some people worry about what's in the vaccine, and these vaccines don't contain any animal products. So we've got no beef, pork, they're not grown in hen's eggs, for example. And so we've actually got most of the products from normal we find in our body, medicines and other foods. Now you'll know that the Joint Committee for Vaccine Immunisation, they actually have set the criteria for who gets the vaccine, and we are working down the age groups, and I'm going to just show you some data for Havering in a moment. But age is considered the most important factor for becoming severely unwell and being in hospital. That's why we started to obviously vaccinate the older population first and come down through those age groups. I'm going to spend a couple of minutes on this slide because I think this one is probably one of the more important points, and this is a challenge for any new vaccine. And it doesn't have to be COVID, it could be measles, mumps, rubella. We not that long ago had the new meningococcal meningitis B vaccine. And so we always go through these stages. Now, the first thing is we have to think about how many doses do we need? And as we know, we need at the moment 2 doses to give us the most protection. How effective is it? And does it protect us against other strains? And I'm going to just talk here about, you've heard again in the news, there's been an increase from the variant that originated from India, that's increased today. Now, our vaccines after 2 doses are looking good, sort of in their 80% for that variant. Also, they're looking good for the variant for the Kent virus, which is called B117. So they may not be as effective as they are for the original variants, but they certainly are still effective for severity of disease. And I think what will be important in the future as well is these viruses will mutate. That's what they like to do. A flu every year mutates. So we have flu, we have influenza A from Brisbane or influenza A from California. So wherever the virus mutates, we give it that name. So this is why we've got the Kent variant, the Indian variant, the South African variant, the Brazilian variant, etc. So we're used to keeping track of these variants with influenza. And so we change and tweak our vaccines every year. And I think that's what we'll be doing here. So we'll start to see as we boost in the autumn, we'll start to see covering these type of strains. But the good news is that they definitely cover against severity of illness, even though they might be slightly more transmissible. Cross protection is important. So, cross protection, as I just said, about different strains, safety and cost, very important. The disease factors on the right here, we know the incidence of disease. We know it tends to affect the Severity is more in older people. We know we have long COVID, and I think long COVID is one of those things we can think about for all ages. And we know the death rates. So we've learned a lot from this time last year when we think where we were last year. And the NHS have done just an amazing job. I mean, the logistics of rolling this vaccine out at speed that we've done is just amazing, especially when you think of these things like cold chain and the Pfizer vaccine that had to be frozen. So there was all those logistics, and we are there now. And then we're here, really. I think this is what we're looking at now, the population factors. It's about acceptance, isn't it? It's about, if you're worried about a vaccine, being able to come to things like this and ask people your concerns. And obviously this thing called herd protection is, you'll have heard a lot of that from Dominic Cummings, I'm sure, if you've watched what he said yesterday. But what we're trying to do with a vaccine, I think really vaccines are about herd protection, is the more people you've got vaccinated, then the less that virus has got. And I often think of the virus as a little Pac-Man, if any of you remember Pac-Man, and it's trying to find the easiest way through. So if you've got people vaccinated, that virus has got to sort of fizzle out somewhere eventually, which is what we hope. So last final bit was how in what have we been doing in Havering. Now, obviously, you'll know we've had this first approach, this national level approach, where you were invited, people were invited to mass vaccination sites. And now we're on really this local NHS level now, where you'll get a text message, a phone call or a letter to be invited to the vaccine, for the vaccine. And these are our uptake rates. So now they are of 14th of May. Funnily enough, the data comes out tomorrow. So these are as up to date as we've got them at the moment. But we are doing really well in Havering. And well done again to everyone in Havering, because if you look at in the green, are the rates we are higher than in the rest of North East London. So you can see we're doing so well, 94% here for aged 80s and above. You know, all of these groups aged up to 50, getting these sort of uptake rates is fantastic. Obviously they're lower in the lower age groups because we've only just started to invite those people forward, and that's first dose. And then you can see our second dose, we're working on that at the moment. So there's only 2 in red that will be slightly lower than North East London, but these are fantastic achievements. And then this, I think, is again important. We talk about a lot about different community groups, and here you can see that they are lower in Asian and Black groups. They are still higher than North East London, but they are lower. And this is something I think we need to give people more confidence and to be able to ask more questions, and why people aren't coming forward as well. And then my final slide is for everyone really, and I think this is important with any respiratory virus, is that even though we're all vaccinated, nothing is 100%. And so this is our Swiss cheese model. So every bit of our cheese has got a hole in it, and the more you can join up the cheese by doing all these different things as we start to come out and mix more, the safer we'll all be. So I don't know what the government are going to say on the 21st of June, because we've got this new variant and it is going at pace. They may still talk about masks indoors, but certainly things like ventilation, I think, are really important. Being outside, going to test if you've got symptoms, washing your hands, cleaning, and coming forward for vaccination as well. So I'll leave it there, and I will be here to answer any questions. Thanks for listening.
So I joined because I thought it was about the pregnancy and the vaccine. So I'm not too sure if this is the right forum to answer the question. But I'm 32 weeks pregnant, been absolutely fine. I've got my text message from the NHS to say that, you know, I'm due my vaccine. So I suppose what my question would be is, if I've been fine up until now and I've got 8 weeks to go, less than 8 weeks to go, what are the risks in not having it? Because I noticed that people have been talking about stillbirths, etc., a bit more in babies. I don't really know the context around it. Or should I wait until I've had the baby's safe and sound, and then perhaps have the vaccine afterwards, because I definitely want it afterwards, but I'm not too sure if I would, that there's been enough research to know what the long-term effects for the unborn baby is.
Okay,
So that's my question.
Aruna, you look like you're going to respond to that. And then could I ask other questions just to go in the chat for us rather than coming on, so that we'll look to group questions together so that we can answer them.
I've got the answers to all these questions in my presentation.
Okay.
If we go to the presentation, maybe it becomes easier. And I will tell you, there is a
Okay, so I think we were moving on to you anyway, weren't we, Aruna? You're next.
Okay, so I'll start sharing my screen.
Thank you.
Dr. Addei is next.
Yeah, actually, I'm next.
Oh, I apologize.
That's okay. Okay.
Who is doing it then, me or Dr. Addei?
So if we get Dr. Addei to come on, that would be fantastic. And then we'll come back to the question, Michelle, when Dr. Ramineni does her presentation, to see if that answers it. And no problem at all, Michelle.
Is my screen sharing?
Not quite yet.
Oh dear.
Here we go. That's brilliant. Thank you.
It's fine. Oh dear. Not sure what's going on, but right. So I'll talk to you about the population aspects of the vaccine, of why it's important to have the vaccine. As Viv has explained, quite a number of people need to have the vaccine for it to be effective. Now, one thing that people don't realize is that there is actually an iceberg of infection. And we talk about the iceberg of infection because not everybody who gets the infection actually goes on to get the disease. And I thought it's quite important to highlight the fact that for 3 people who get the infection, they will not be tested. So we will not know they have the infection. So the bottom of the iceberg is quite large. And that's something that a lot of people don't take into consideration. So when we listen to the Downing Street briefings, what we are hearing is the tip of the iceberg. So we hear about those in hospital, we hear about those in critical care needing ventilators, and we hear sadly about those who died. But it's quite important to note that a large number of people carry the infection within the community and we don't know about it. So park that. The other thing I thought it was important to highlight is, as Viv said, vaccines are something we're quite used to. So we all know about the MMR vaccine. We know about the yellow fever vaccine. It could be hepatitis B. Vaccines are not new. They are something we've used to fight infections for a long time. And as Viv said, the thing that the vaccine does is to almost in a controlled way, mimic what you would get when you have a natural infection. So you get a natural infection, your body moves to respond to that infection. What the vaccine does is to mobilize your body without the infection so that you don't risk the significant side effects of the disease. And that's what vaccines have done all this time. I thought it was also important to highlight the fact that historically, we've always used vaccines. Vaccines are nothing new. So it's because of vaccines that we've moved from hundreds of thousands of cases to almost no cases at all for a lot of these common diseases. Polio, a lot of people may not remember. I mean, for most of us on the call, we won't remember polio in the 1950s, but this was a ward in the United States where they used iron lungs to support people who had paralytic polio. Now, it's the polio vaccine that has caused us to move from this situation in 1988 to what it was in 2017. And it's estimated that we've averted 16 million cases of paralytic polio by vaccinating in this time. What hasn't been calculated is the number of deaths that have been averted. So the important point I want to make is vaccines are important. Viv talked again about herd immunity. And I thought it's important to show you why it's important to vaccinate a population. So this is where we were in the early phase of the pandemic. We talked about hand-face space, we went into lockdown. Most of the people were not immunized. They could get sick and they were contagious, okay? So very few people most people hadn't come in contact with the vaccine, with the virus, and so they could get unwell. So when they came in contact with it, they became unwell. Then we got into a phase where we've started vaccinating people, but we've still got, especially in the minority ethnic groups, as Viv said, we've still got quite a number of people who have not been vaccinated. And so there's still quite a number of people who can get the infection, and that's the dark red people. They, you know, once the infection comes into the community, they can get it. Where we want to get to is a place like this where a majority of the people have been vaccinated. And that means if someone gets the infection, you would see, because people have been vaccinated, they are not coming in contact with people. And that's how the spread goes down. And so then lockdown can be removed and we can all go out and have a good time, almost. They've talked about the impact of vaccines. It's been shown to decrease deaths, it decreased severe disease, it decreased hospital admissions, it's decreased transmission, that's passing it on to one another, and it's decreased the number of infections. Not zero, but significantly decreased. I thought I'd hit one of the questions I get asked whenever I do one of these things, and that is that ethnic minorities are being used as experiments. Trials were carried out in over 50 countries, 4 were in Africa. If you look at the map of those who've had it, very few have been given in Africa. Not that that's a good thing, but it's to show that of the 50 billions of doses that have been given out, very few have been given to Blacks. So it's not an issue of experiments. It's not an issue of ethnic minorities being given the vaccine as experiments. Vaccine passports will be forced and will be used to monitor us. And there's been quite a lot of that on the press. I think it's quite important to note that our mobile phones are very easy to track, and also that we are quite used to traveling and having to take vaccines. For many people who travel to the Hajj, for example, they have to get the meningococcal vaccine. We don't bulk at that. When people are traveling to different parts of Africa, they have to take the yellow fever vaccine. And different countries have different vaccines. So it's never really been a problem in terms of having something to show that, you know, you've been vaccinated. It's something that exists even now. And then the other thing that I thought worth saying is about spreading myths. WhatsApp is not a doctor. The clips, we get a lot of clips on WhatsApp. We get a lot of clips from various groups, a lot of information. Go to trusted sources for information and don't pass on clips or information that may be suspicious. check your sources, go to the gov.uk site, go to the Havering website, the BBC, the World Health Organization. They are all good sources of information. And finally, what I'll say is that the concept of vaccinating a population is nothing new. A lot of us have taken our children for vaccines. We are all at risk of being infected with the SARS-CoV-2 virus. And so once we get vaccinated, it reduces the chance of experiencing what I explained as unpredictable outcome when you get the infection. You don't know if you'd be one of those who end up in hospital, and you don't know if you'd be one of those who gets a very serious infection and needs to be on a ventilator. When you take the vaccine, you get mild side effects, as Viv had said, and then you do go on to get immunity. Okay, so it's quite important that we all get vaccinated to make sure that there's a high level of vaccinated people in the population, so that the number of infections and hospitalizations, and sadly, even the deaths, continue to remain low. Thank you very much.
My apologies, I was talking away, but I was on mute. Thank you so much, Dr. Addei. Really, really interesting, particularly kind of taking that broader view of, you know, vaccines have been around for a long time, but that absolutely doesn't take away from the real concerns that I'm starting to see come through on the chat, real worries. So that's why we're here tonight, is to do our best to answer those questions. And we're, as I said at the beginning, we're more than happy to pick up things that we may have missed off as we go through the presentations. So I'll get it right this time. Dr. Ramineni, thank you.
Hello again, I'm Aruna Ramineni, consultant obstetrician gynecologist working at BHRUT, and also lead the fertility unit in Queen's Hospital BHRUT.
You're quite soft. Can't hear you so well.
Okay. Is it better now? I'm a bit clear.
Perfect. Thank you.
Okay. I'll start sharing my screen. So to introduce myself again, I'm Aruna Ramineni, consultant obstetrician, gynecologist, and fertility lead, and I can answer all the questions on the chat box if I have the time. So, are you able to see my screen now?
Yep, we can see it. Thank you.
So I'm going to talk about the vaccine and pregnancy and fertility. So the good news is the majority of pregnant women who are infected with coronavirus will be asymptomatic. The studies report anything between 70 to 85% are asymptomatic. Okay. Then, when you have a pregnant woman with the coronavirus infection and a non-pregnant woman, the pregnant women will have higher rates of intensive care admission. It may be because the doctors are admitting them because of the pregnancy into the intensive care units, but what we have seen with our studies is that there is higher rates if you are pregnant. Then again, those requiring hospitalization have overall worse maternal outcomes. So that could be an increased risk of death, but the risk is still quite low. The risk in UK is 2.2 per 100,000 maternities. And if you compare it, the overall maternal mortality rate is 9.7 per 100,000 maternities. So the risk is low, but there is increased risk of dying if you're pregnant and have the coronavirus. Then, what are the increased risk factors for hospitalization? So if you are Black, Asian, or a minority ethnic, your risk factor, your risk is more. If your BMI is more than 25, the risk is more. Most of us here have a BMI of more than 25. So that's pretty common then. And pre-existing diabetes and chronic hypertension again increases your risk. If you're older than 35, that increases your risk. And if you're living in areas of households of increased socioeconomic deprivation, again, it increases your risk. How does this infection affect your baby? There is increased risk of preterm birth. So our estimates are about 17% to 25% of increased preterm births. But you also note the word iatrogenic there. And so it's because the infection is not causing preterm labor. It is when a pregnant woman is infected, in order to take care of her, in order to give her the care, the doctors might be delivering her early. So that is leading to preterm birth. But otherwise, the coronavirus infection itself does not affect the fetus or the neonatal outcome. This is the standard message from the RCOG and the HFEA and the government websites. The overall rates of stillbirth and neonatal death is very low in women even with COVID. So the JCVI and the WHO have recommended that the vaccine can be received whilst breastfeeding. So there is no question that you shouldn't be taking the vaccine when you're breastfeeding. Yes, the answer is a definite yes, you can have the vaccine. So the Joint Committee has advised that pregnant women should be offered the COVID-19 at the same time as the rest of the population based on their age-specific clinical risk group. So as one of our participants had asked, that this is why she was offered the vaccine that she was offered. So the JVC advises that it is preferable for pregnant women to be offered the Pfizer or the Moderna vaccine where available. This is not because AstraZeneca is more dangerous, it's because there's a lot of studies, about 90,000 women were studied in the United States where the Pfizer and Moderna were used. And because the data is that it is quite safe, that's why we are preferring to use these. So as I said before, it is going to be offered to a pregnant woman at the same time as everybody else based on their age and clinical risk. And trial testing vaccine in pregnancy and breastfeeding have not taken place. So we haven't had those kind of studies, so we can't with confidence say we've done this trial, this is our proof. So whether to get the vaccine in pregnancy is your choice, and I will show you how you can go down this tree. So do you want to get the vaccine or not? It's your choice. Your options are get the COVID-19 vaccine, or you can wait for more information about the vaccine in pregnancy. And so far, I've shown you that, yes, when you get infected, your risks increase, but overall, 75 to 80% of women do quite well. So, so vaccination, I mean, there's pregnant who are at increased risk. These are the health or social care workers. And if you are at high risk of COVID-19 due to health and personal factors such as age, ethnicity, BMI, and underlying health conditions. And women diagnosed with gestational diabetes in pregnancy, these are at increased risk, and women with a BMI of more than 40. So what are the benefits of vaccination? So the benefits are the hospital admission and severe illness may be more common in pregnant women, especially those in the third trimester of pregnancy. And again, the iatrogenic preterm birth is more likely. So pregnancy, again, in women who have an underlying condition, they are more at risk of having a severe illness. So again, to remember, the COVID-19 vaccine do not contain live coronavirus. They do not contain any additional ingredients that are harmful to the pregnant women or their babies. And we've got experience with other non-live vaccines, such as the whooping cough and the influenza, which are considered to be quite safe for pregnant women and their unborn babies. And it is effective. It is quite effective in preventing COVID-19 infection, and you cannot get COVID-19 from vaccination. So as I've said before, they have not been tested specifically in pregnant women, the vaccine. But from the United States, where more than 100,000 pregnant women who had a COVID-19 vaccine using the Pfizer or Moderna vaccine, they haven't had any safety concern. We do know that there's extremely rare but serious side effects involving thrombosis have been reported from the AstraZeneca, which is 11 per million. I know it varies according to the age group. So this is an average of 11 per million. The Pfizer or Moderna vaccine should be offered to pregnant women where available, as most of the safety monitoring data from the United States relates to these two vaccines. There are some side effects when you have the vaccine, as has been mentioned before, such as a sore arm, fatigue, headache, muscle pain, fevers, and joint pain. At whatever stage of pregnancy, you can have the vaccine. When you're having a vaccination, you do not need to do a pregnancy test. And if you're planning, if you want a baby, you do not have to delay your pregnancy until you get the vaccination. They can all go side by side quite happily. However, as COVID-19 has more serious complications in later pregnancy, some women may choose to delay their vaccine until the first 12 weeks, because the first 12 weeks are very important in the organ formation for the baby. Once the 12 weeks you cross, there isn't much risk. I mean, even though there hasn't been any evidence that it affects even before 12 weeks, it's just being safe to use it after 12 weeks. If you have underlying medical conditions such as immune problems, diabetes, high blood pressure, heart disease, or asthma, if you're overweight, if you're over the age of 35, if you're in your third trimester of pregnancy, you are more likely to have a serious effect of COVID-19. And if you are at a higher risk of catching COVID-19, you should consider getting the vaccine. You should discuss the risks and benefits of vaccination, including possible side effects of the different vaccines, with a healthcare professional before making your final decision. Now, coming to fertility, people of reproductive age are advised to have the vaccine when they receive their invitation for vaccination. This includes those who are trying to have a baby, as well as those who are thinking about having a baby, whether it is in the near future or in a few years' time. There's absolutely no evidence and no theoretical reason that the vaccine can affect the fertility of women or men. And yes, you can have the vaccine if you're going for IVF, frozen embryo transfer, egg freezing, ovulation induction, IUI, or using donated gametes. So all these I have prepared. My references are from the Royal College of Obstetricians and Gynecologists, the HFEA, and the British Fertility Society. I have another leaflet about making a choice, and I will just share my screen with them. So again, this is a decision aid that's been published by the RCOG. So the question, I'm pregnant and have been offered a COVID-19 vaccine. What are my options? So, as I said, it's being offered to pregnant women at the same time based on age and clinical risk. Trials are not there, but whether to get the vaccine or not is your choice. So as I've said, who can be vaccinated? So these are all the people who are being vaccinated when they're pregnant. Health or social care workers, people considered at high risk, women with a BMI of more than 40. And then I've mentioned about the benefits of the vaccination and how it is effective in preventing COVID-19 infection. And these are the side effects. And there are more links here, more information here. So if you go onto the RCOG website, you will be able to see all this information. So thank you very much for letting me share my presentation, and I will take the questions later on.
Okay, thank you. Thank you very much. Really interesting. and you know, from my perspective, provide some reassurance. We certainly had lots of questions, as you saw in the previous presentation, coming through on the chat, and we've had a few more since. So I'll give you a chance to kind of flick your way through them, just so you can just check that you feel you've answered them all. But thank you so much for that, Aruna. Really good presentation. So I move on now to Dr. Baldwin and Dr. Barrett, just to come on and say a little bit about what's happening in Havering from the perspective of GPs, and then we'll come back to a Q&A session for all of our panelists.
Good evening, everyone. As I introduced myself earlier, I'm Dr. Barrett and I'm a GP in Havering. It's important to tell you that GP surgeries are open. We have been open throughout the pandemic, although we have been working very differently to how we have previously worked historically. And this is mainly to protect patients and staff. So patients will likely be aware that we've been operating a telephone triage system, which means that we have been conducting telephone consultations or video consultations, or a mixture of the two. However, if we feel that patients need further clinical assessment, we will invite patients in to be examined face to face, but that's purely on a clinical need. So we do this in a way which follows public health guidance. We do this by social distancing and by the wearing of face masks and PPE by clinicians. We are offering non-urgent screening as well. So we are offering cervical screening, which are smear tests. We're offering routine postnatal care, and we're continuing to do childhood immunisations as well. And we encourage patients to book these when they are due. And normally you will be notified by the surgery when they are due. We encourage and welcome our patients to discuss all health concerns. Our staff are trained to direct patients to the most appropriate healthcare provider, whether this be the GP, it could be the practice nurse, it could be the local pharmacist, or even a social prescriber. And if staff are unsure whom a patient should speak to, they will always discuss the case with a GP so that we can make a decision about how the patient gets seen and when. Practices are also accessible by e-consultation, which can be found on your practice website. So this is a way of communicating with us by an email type form. And it's particularly useful for clinical queries, which are quite short and brief. This might include medication requests and queries, sickness certification as well. It's not so useful for complex medical problems that probably need discussion on the telephone. But we are open for service and we welcome people to contact us. I think through the pandemic, we saw a lot of people quite fearful of contacting us. However, we are back, gaining lots of momentum, lots of people phoning up for appointments, and it's been extraordinarily busy recently. So please do bear with us as well. Thank you.
Thank you so much for that. Is there anything you wanted to add, Anne?
Thank you, Barbara. Yes, it's Dr. Baldwin. Just to add on to a few points, to say that general practice has adopted suddenly different way of working during COVID pandemic. And I just want all the people to know that we try our best to keep our practices open in spite of our workforce issue, people being ill, staff being not well, some of them has to isolate. And with all this, and we kept our practices open, we prioritize the age group, the woman, the screening program, and vaccination and children immunization. And we did it with the all the measures of public health around infectious control measure. We took all the advice and we have kept it open and safely throughout the pandemic. And we continue to do that. And like Gemma has suggested just now, that we have a different way of working. And I think patient may experience that, we are not seeing face to face. It's all because we follow the guidance, and we have to follow safety for the patient as well as for our staff and clinician. And that's what it is. And you might experience that you have a difficulty trying to contact on the phone, and it's because there's a high volume of phone coming in. So hence we encourage a lot of younger generation and able generation and able group of patients who are able to use technology and telephone, smartphone, and e-consults and other way of communicating to our general practice clinician. And that's how we have helped and support our community. And plus COVID vaccination program, you know that we have 2 sites in Havering, and we have provided all the workforce. We work with the PCNs, and our doctors has been, kind of leave their normal work and go out and do vaccination, and over and above, their work contracted time. So as our nurses, our ACAs or healthcare assistants, our pharmacy colleague, and clinical pharmacists, whoever is able to participate in this program, we have done as in collectively and as in group. So hopefully that will help people to understand general practices and a lot of demand, and we try and do our best, and we continue to try our best. Thank you.
Okay, thank you so much, Anne. And certainly from a council perspective, we have been really, really grateful for the efforts of our health colleagues in Havering, for the stupendous amount of work that you have done around vaccinations, certainly since December and ongoing. So thank you so much for that. Okay, I wonder if Dr. Addei and Dr. Ramineni would like to just come back on, having had a chance to look through some of the questions, to take a view as to whether you feel you want to answer it, or forgive me, able to answer it.
Shall I start then? I've started.
Yeah.
I'll go in an order and look at the first question. What advice can you give to women who are trying for a baby in relation to the vaccine? As I've said, you can have the vaccine and you can try for the baby. There is no problem about that. Can they continue trying after the first dose? Yes. Do they need a specific vaccine? It's age specific, as I've said. For people younger than 40, you're offering the Pfizer and Moderna. And again, as I said, in pregnant women, we are, because of the data from US, we are preferring Pfizer and Moderna.
Okay, that's good. Thank you. The next one, I think you did cover off, but just to confirm for Nadia, those that are due to start a cycle of IVF.
Yes. You can.
So, okay, that's fantastic. Kanisha's asked how much sort of data and research has been done regarding the vaccine, and any research on the impact that it might have in different trimesters.
No. We don't have research on that.
Okay, is that planned? Do you know?
Yes, there is one planned. I'll have to look at to get the name, but yes. But as of now, we don't have.
I think the only thing I can add is that there is evidence from the United States and actually across the world on people who have been vaccinated and then gone on to have babies. Mm-hmm. But as for all other drugs and vaccines, we will not normally test them on pregnant women in the early phases. So we do what we call pragmatic trials. People have had the vaccines, they've gone on to get pregnant, and then we monitor what happens to them afterwards. We don't have evidence at this point in terms of trimesters because it wasn't planned. So that's why we don't know. And then I saw a question too about the long-term effect on children, on babies. That evidence isn't there. The vaccine hasn't been, it's not quite a year, so it's only now that babies, people who have had babies would be followed up, but we don't have any long-term information. But as Viv explained, vaccines are something we have used. And so we do know that, we give our children vaccines. So we do know that children can have vaccines like the MMR, BCG, polio vaccine. So it's not something that is totally foreign to children, to babies.
Okay. Thank you so much for that. There's a specific question on any impact of, I won't say the medicine, but in terms of fertility medicines.
No. And that medicine, prednisolone, is not a fertility medicine anyway.
Okay. And then we had a question there from Kalisha, which I think we've answered probably insofar as when trying for a baby. A question there from Pauline, who says, I am Black and I worry about having the vaccine. And is there an option of finding out which vaccine it will be?
I can answer generally. I'm not sure what happens in Havering. Okay. I do know that generally in deploying the vaccines, it won't be difficult. It won't be possible to know which vaccine you're going to get. We always say the best vaccine for you is the one in your arm. Okay, so that's what we go with. The clinics don't know which ones they're going to get. It's run on a schedule. You get what you get. Get it in your arm. That's what's important.
Yeah. And I think, Pauline, as has been said, certainly those that are under the age of 30, if that is your age, would be directed towards Pfizer. But just at the moment, we're not really able to say, go here for this particular vaccination or go or book there for a different vaccination. Is that true, Gemma and Anne, from your perspectives?
Yes, so as Dianne rightly said, the vaccination delivery is very, very acceptable. Sorry, we can't really know in advance that which one we're going to get sometime, and it's all in, sometime on the same day or sometime 24 hours in advance, and we have to prepare all our clinic, open up the booking system, and sometimes that information doesn't really get to practices. So to maximize the vaccination program, just we focusing on certain age group at certain time. So we have a time scale to work it through. So within that time scale, we would invite that group of patient and prioritizing high risk, and then work our list down to the lower risk and the different age group. So hence, sometimes it's difficult. But if pregnant women we started to vaccinate, and we try and make sure that it's a Pfizer vaccination a day, and we won't advise practices to book any pregnant woman in any other day.
Okay, that's really helpful. Thank you, Anne. We've talked already, Caroline's question about research in terms of having the vaccine early in pregnancy. It's just too soon to say at this stage. However, there's nothing to suggest that there is any more risk than with other vaccination programs. Yeah. And I'm glad that the panel is nodding at me.
Yes.
So thank you for that. Michelle's asked if there's a best time to get the vaccine if you're in your first trimester of pregnancy. Should she wait until 12 weeks or later?
Yeah, I mean, though there is no evidence that it causes any harm, I think generally all pregnant women avoid everything before 12 weeks. So yeah, after 12 weeks is a good time. But there was another question before that.
I'm sorry. Kalisha had asked about the impact of COVID on an unborn baby if the mother gets it.
And we know the answer to that is that COVID itself does not cause anything. It's not transmitted to the baby. But if the mother is admitted, there could be iatrogenic prematurity for the baby.
Yeah. Okay. Thanks for taking me back there. Megan has asked if she needs to switch to the Pfizer jab, having first had an AstraZeneca jab.
No, because if she's had AstraZeneca and she didn't have any problem with it, so she can very well have it.
Okay, so what Megan's saying is that she spoke to her doctors and they wouldn't switch it out to Pfizer. So from your perspective, that's correct.
She can have the Pfizer, but she can have the AstraZeneca as well, because with the first dose she did not have any problems, so she shouldn't have any problems with the second.
Okay.
I think again we missed a question from Nicola.
Oh, yes, quite right. You should be hosting this, Aruna, rather than me. Okay, to breastfeed after having the vaccine.
Yes.
That's great. So I am going over questions which I think we've already answered, but if you think I've missed out on something, absolutely do come back in. So Laura asks, and this is something that comes up quite a lot actually, not just for women who are pregnant or trying to get pregnant. If you previously had COVID and had a mild illness, is there a need to still get the vaccine?
Yes.
Yes. So I think Viv's presentation kind of covered that insofar as the immunity that you may get from either having had an infection or through vaccinations. It will last only a certain amount of time. So it's important that we remain in that cycle, if you like, of keeping ourselves safe with vaccines when they come through. Julian asks about his daughter-in-law. Is she at higher risk because she's mildly asthmatic and works in a nursery? She did have the AZ vaccine. She's now become pregnant and just had a 12-week scan. Is there anything you want to kind of comment on that one, Aruna?
I think it's similar to the previous question. She can have the AZ vaccine. Yes, and she also is an asthmatic, and so I think, yeah, she can have the second dose.
Okay, thank you. Michelle talks about the just concerns about the vaccine hasn't been around long enough. So just wanting to understand if there are any risks in not having the vaccine at this stage in pregnancy, or would you recommend that she goes ahead and has the vaccine at 32 weeks pregnant?
So I've said, it is her choice. There are increased risks for pregnant women. There are increased risk of hospitalization and of prematurity. So yes, if you look at that risk, you should go and have the vaccine. But again, the overall number of people who are being affected is also quite low. So she needs to make that decision for herself.
Thank you for that. Karen asks if she should wait until her baby is born. That's and the breastfeeding question, which I think we've covered already.
Yeah. As I said, yeah, look at your risks and benefits, and yeah, I would say go for vaccination. Again, entirely.
Courtney asks, it seems to be getting some conflicting information about whether to have it or not.
Yeah.
Shall I leave you to ponder that, Aruna?
So I think there's something about breastfeeding. Again, yes, you can take the vaccination when you're breastfeeding. Yeah, so she's breastfeeding and she qualified for it. And yes, I'm happy, absolutely.
Yeah.
Be able to have the vaccination.
And there's just a question, if the research hasn't been done, how do we know that breastfeeding is okay with the vaccine?
So through the breast milk, what goes to the baby is antibodies rather than the virus itself. And we've seen that there hasn't been any transmission of infection. So, and we also know the vaccine itself, the constituents are not harmful. So that's why I think it's, and all our important bodies, the government website, the RCOG, they've all quite empathetically said that.
Yeah.
During breastfeeding, you can have it.
Okay.
If I may add, the thing about vaccines, which I've said, we're used to using vaccines. The reason we delay in giving the measles vaccines, for example, to children is because when you breastfeed, you pass on antibodies, as Aruna said, so we're used to passing on antibodies from vaccines the mothers have had. And that's what confers protection onto the children for a certain period. So we know, for example, that when you take the measles vaccines, and that's another reason we avidly encourage breastfeeding, because you want to pass on that passive immunity to your child while your child's cells are building up so that they can form their own antibodies. They get mom's antibodies from the breast milk. Okay, so it's something we actually encourage, that you actually breastfeed your children. You pass on antibodies, so it's fine.
Okay, thanks for that. And I think Courtney has also asked, perhaps later on, a clarification about waiting for the child is past 18 weeks before taking the vaccine if breastfeeding. I think that the answer is the same.
Yeah.
Yeah. Okay.
Have the vaccine.
Thank you. Lindsay's asked about the increased likelihood of pregnant women with COVID being admitted to hospital.
Yeah, more admitted to ICU, and that is again because it's because doctor, a pregnant woman, if she has the infection, is at more risk, and you might be doing it more as a precautionary approach as well. But that definitely is what the statistics are showing, that they are being admitted more. And again, the preterm deliveries is also because when you want to ventilate, when you want to save the mother, help the mother, you'll have to then deliver her. So that's why we're probably having the iatrogenic preterm deliveries. Yeah, as Lindsay has explained in the question, it is because doctors are exercising greater caution.
Yeah. Okay.
It could be because of the doctors are exercising greater caution. Yeah.
Yep. Okay. And I think you'd already covered in your presentation that that COVID does increase some chances of complications, or is more, or can in pregnant women.
Severe, yeah.
Yeah. Okay. Charlotte asks, she's heard that women who have had the vaccine have experienced irregular periods, and some haven't had any since the vaccine.
So in my clinic as a gynecologist, 40% of women have this problem anyway. So it's not vaccine. Irregular periods, missing periods is one of the most common problems that women have.
So you wouldn't at all associate that with having had a vaccine?
No, not at all.
Okay. Grace again has just asked about the question of vaccine whilst pregnant or breastfeeding if we don't have, if there hasn't been trials. But I think Dianne covered that really well previously. Thank you to our GPs, which I do want to read out from Nicola. Her practice in Upminster has been fantastic. The Kalish's looked at the handout, and it states that some women in the US fell pregnant soon after having the jab, but not enough is known about that. So Kalish's just still feeling concerned about going for her jab when actively trying for a baby.
I think it's best to get the jab and be immune when you're trying for the baby, but that's me.
Yeah, and you certainly had put in the link to the leaflet that supports people with some of their questions. Bobby's just asked if the issues around research, is there a concern for the fetus rather than fertility?
So when you do research, you need to specifically set the group, and you have to give it to pregnant women. So that's why you're not able to do research in pregnant women. And I don't think we'd be able to get any of those data anytime soon. Whereas for fertility, as to why further research is needed for pregnancy. So for the reason that it's difficult to do research in pregnancy, but not for fertility when no one has had the vaccine, conceived and had a baby yet. Because we know it does not, so fertility is not just about delivering the baby, it's also the ability to have the egg, being fertilized and being implanted. So I think we know that it doesn't affect that part.
Okay, thank you. I think Tom's question's been answered insofar as the antibodies pass through to the baby. That was in the context of breastfeeding, but I assume that's also the case in pregnancy. And Viv has corrected me. Thank you for that, Viv. It's actually all those under the age of 39 are directed to Pfizer. So thank you for that. Karen asked for a view on the effect of the vaccine on unborn babies and then developing infants and children. And this is in respect of her daughter-in-law who's 6 months pregnant and 35 years old.
So we know that the coronavirus itself does not cause anything, does not damage the baby. And we know from the vaccine, it is the antibodies that will pass to the fetus and the baby. So again, I would say it wouldn't really affect the unborn baby. Yes, we haven't had the long-term data about that, but we have the data from other vaccines.
Yeah, okay. T asks if the vaccine can be mixed whilst you're pregnant. So if you've had one, say, AZ to start with, are you able to have Pfizer as your second dose if that's all that's available?
I think you can have it, but if you haven't had a bad reaction to AZ at the first instant, you're safe to have it in the second instant.
Okay.
I'd add the advice is that if you've had one vaccine, you have to follow with the same one afterwards. There's no mixing and matching at the moment. So the advice is you have one and you have the same one as your follow-up.
Yeah, thanks for coming in on that, Gemma. A question as to whether the virus itself causes fertility issues.
No.
Okay. So Courtney, we've covered the point on antibodies passing through baby in terms of women who are pregnant. There's also just a question there around the placenta. So there's in terms of what risk that might leave for the baby.
So there are two things, antigens and antibodies. So the vaccine, the antigen will not pass, but the antibodies, which are the protective mechanism, that will pass through.
So antigen is the disease itself,
yeah.
And antibodies are what comes from the vaccine. Yeah. Esther, I know you've just joined. I'm hoping you will have picked up already that the advice is it is absolutely fine to have the vaccine while breastfeeding. Courtney's come back just saying that she doesn't feel we've answered fully. Is it right to wait until the 18-week immunizations of the baby in terms of breastfeeding, or does that not matter?
It does not matter. You can have the vaccination. You do not have to wait up till 18-week immunizations of the baby.
Okay. Bobby's just made a point about research, which absolutely understand your concern, Bobby. Karen say she's 40 and in her third trimester, and it is asking if she may be able to access Pfizer.
Yeah. As a pregnant woman. Yes.
So as a pregnant woman, she should be able to access Pfizer.
Yeah.
Yep. Okay. Okay. Grace, we've kind of covered that earlier, and we're going to make this available, the question on okay to breastfeed without trials. We're going to make this presentation available on the council's website, so you'll be able to kind of pick up responses there. And then Courtney's just come back and say, don't worry, Grace, no time's a good time when you've got a baby to get to sleep. I totally understand. Courtney's raised again that the vaccination centres told her to wait until she until her daughter rather had the 18 weeks immunisations.
I don't know.
That sounds like something we may need to take away, Courtney, and we'll add that into our FAQs that will sit with the presentation when we publish it. And Karen has asked how to confirm to request a particular vaccine if you are already pregnant. So I don't know if Anne or Gemma, you can advise on that.
So women that are known to be pregnant will ideally be offered the Pfizer vaccine as preference. If for any reason patients are allocated the AZ vaccine, they should get in touch with their GP practice just to let them know they are pregnant, but this is on age. So everybody who's under the age of 40 should be offered the Pfizer anyway. If there are any pregnant women over the age of 40, just ensure that you are being offered the Pfizer.
So is that to be arranged through Karen's GP?
So that would be your GP or your who will help book you into the local vaccination centre. And if you get a message from the mass vaccination centres, then they may not be able to tell you, but hopefully your GP can organise the correct vaccine.
Okay. And Leah's just asked, because I'd certainly heard on the news today as well, that they're looking to reduce the length of time for the vaccine from 12 to 8 in some circumstances. Any thoughts on what that might do to immunity? That sounds like one for Viv.
So I've got a little picture actually. I thought I read that one. Can you see that?
Yeah.
I see. There's a really good question, Leah. And if you can see from this little presentation, so when you have I'll pull that up a bit more. So when you are either infected or you're vaccinated, you can see the red line. That's your primary immune response. So it starts to sort of increase, and you get all your antibodies. And then when you're next infected or you have your second vaccine, you can see this sort of massive increase in your antibodies. They got much more quickly, and they last longer. Now, some of you will remember when we first brought in these the immunizations, a lot of the vaccines are actually recommended to have 3 weeks apart. So actually, a lot of the trials were 3 weeks apart. So you'd have one vaccine, 3 weeks later, you'd have your booster vaccine. Now, what we did from a public health point of view really was we wanted to make sure we secured enough vaccine, and we wanted to make sure everybody got at least one dose to protect people and to bring the numbers down. And then some more research has come out since subsequently that actually leaving it up to 12 weeks was fine. So we kept it at 12 weeks. So it doesn't actually make any difference that we've brought it forward. So you can actually have the vaccines from anything from 3 weeks, 1 to 3 weeks, to the 8 weeks to the 12 weeks. All that second line, all the second vaccine is doing is giving that primary response a boost. So it's actually fine that they've brought it forward. I hope that answers the question.
Yeah, thanks for that, Viv. And I certainly recall the debate at when it went from 3 weeks to 12 weeks, and would that have an impact on whether the vaccine would work. So, and then Karen's just asked again if Pfizer advises the preferred vaccine for those breastfeeding too. So in this instance, I assume baby's already been born, and mum is just wondering whether she should seek or should get the Pfizer versus a different vaccine.
I think it's age specific. She can have anything that's advised for her age group.
Could you say that again for us, Aruna? It's very soft again.
It's age specific. So according to her age group, whichever is advised, she can have any of those vaccines.
Okay, so I think Karen was was over 39 already. I guess that's hence the question. Okay, we've got to the end of our of the questions in in our chat box. A final opportunity for anyone to pose anything extra. Okay, I'm not seeing anything pop up. So I just want to say a big thank you to all of you for joining us. And I hope that you found the session helpful and useful. We will, as I've said a couple of times, get the video from this evening at the presentations, and we'll just flick through those questions again to make sure that we do feel we've answered everything. They'll be available on the council's website as soon as possible. Any idea sort of how long, Yvonne?
We'll do our best. Oh, it's a bank holiday, isn't it? We'll do our best to get it up by Tuesday, if not before. Yeah, I was going to say Monday. Okay. Yeah.
Okay, thank you. And I just want a big thank you to the panelists. So Dianne, Aruna, Viv, and Gemma. The presentations tonight were just so good, and I can see some of our participants sort of giving their thanks in the chat box. So I'll leave it at that, and wish you a good evening, what's left of it. And again, thank you so much for our panelists giving up their time this evening, but also all our busy residents who are potentially mums themselves, perhaps dads or granddads or father-in-laws, and also participating. Did you have a final comment there, Aruna?
Yes, I know the talk is all about vaccine and fertility, but somebody who deals with women who are struggling with their fertility, I would advise a few things, if you don't mind.
Yes.
If you want a baby, please have regular intercourse 2 to 3 times a week. Throw away all those ovulation kits and timing and all that interferes with it. Have a good lifestyle, be stress-free, and that's it. And if you've tried for 1 year and haven't had it, go to your GP and ask to be referred, please. The most important thing that I've learned through COVID is lifestyle is key to having baby.
Okay, thank you for that. And Dianne, I just wondered if you wanted to repeat as a final remark, your statement on what makes a good jab.
Get it in the arm.
Brilliant. Okay, thank you everyone, and really appreciate everyone's time. Thank you so much. Okay, bye now.
Thank you. Bye.
I can end the meeting for everybody to save you clicking. Okay, thank you everybody. Okay,
Thank
good
you.
night.
Bye.
Thank you.
Good night.
Good night. Thank you. Bye-bye.
Bye.
Goodbye.
Bye.